What do people think about the private health care in South Africa?
On private hospital, we get good services. Even if you pay, you give your all, but you get good health care, you're taken care of, you get enough food, you get anything.
In the private sector, there's consequences for action. People will sue you if you actually practice malpractice. People will actually fire you if you don't do your job. And people will actually even manage hospital managers. They're evaluated quarterly, monthly, and yearly. That structure doesn't exist in the public sector.
Waiting time is now worse than government hospitals. You know, I've had a nasty experience where I went to emergencies at one of the private clinics, and I sat there for like 2 hours before seeing a doctor. So for me, I don't see why they're saying we should pay medical aid and get quicker treatment and better treatment when government is now the same.
A private hospital, you're going to get in, administration is going to be well sorted, you're going to get in, do your thing and go out.
The United Nations proclaimed 12th December as International Universal Health Coverage Day. And the theme for the 2019 campaign is Keep the Promise. Now, governments, international organizations, civil society organizations, the private sector, academia and the media are all encouraged to use this year's theme to keep holding leaders, our health systems and ourselves accountable to the promise of health for all. Now, South Africa has an unequal dual system of public and private health care, where the private health care only covers approximately 16% of the population. Now, the challenge is that the cost of private health care has over the years spiraled out of control. Now, according to the Health Market Inquiry report recently released, South Africans are paying far more for private health care and getting less. Now, if these inequalities are not adequately addressed, the dream of achieving universal health coverage by 2030 will not be realized. So today we discuss the cost of private health care in South Africa. And we'll be joined in studio by the Health Market Inquiry panelist, the chairperson of the South African Medical Association, the Chief Operations Officer of GEMS, the Chief Executive Officer of Discovery Health, and the Executive Director of MedScheme. You can tweet us at SABC Health Talk or simply just interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Selomit Daung, and this is Health Talk.
What are people's views on what is making private health care so expensive?
It could be because of the service that they give to their patients. I mean, that is of the difference from what we get from. Remember, it is what you get from the government is poor, hence it's for free. And what you get from the private hospitals, you pay and you get the best out of it.
It is expensive because of you get the attention there rather than the government hospitals.
I'm a private. I say capitalism. That's the whole thing that I can say, because I don't understand.
Within the private health sector, there are no such subsidies. So the hospital has to actually run so that it makes a profit. That means it charges a markup. It means that people pay for everything.
Okay, so we're going to answer all of those questions. I mean, is it that, private health care has better quality and that because, in the public health sector, people go in for free and therefore the quality is poor? Well, we're going to answer those questions and we're going to understand exactly why the private health care sector is just so expensive. Now, to help us with that, it's a great pleasure to introduce our guests. First up is Dr. Ntuthuko Bengu, who is a Health Market Inquiry panelist. And Dr. Bengu himself is a National Planning Commissioner. Welcome to Health Talk, Dr. Bengu.
Thanks, Dr. Mtaung.
All right. And then, of course, we have Dr. Lunginyati. Dr. Lunginyati is an Executive Director at MedScheme, and she's responsible for the managed care strategy. Welcome to Health Talk once again, Dr.
Thank you very much.
All right. Perhaps let's stay with you. In my introduction, I mentioned the fact that, we have this unequal dual system of healthcare in our country. What are the actual problems, if we can just, globally look at our system and, what are the challenges?
That's a very broad question, but perhaps I can start with, in the public healthcare system, generally some of the things that I mentioned relate to quality of care on the main. We do know that the members of the public are able to access healthcare in the public health services for free at point of care, and you pay according to your income level. You generally get access to a comprehensive package, but the biggest challenge has to do with quality. Right. In the private healthcare system, the biggest challenges that we have relate to the cost of healthcare, as we are discussing today. Right. And that's mainly evidenced by the contribution increases. However, that's impacted by the fact that more and more people, especially young people, are choosing not to belong to a medical scheme. And we're finding that the population that's now part of a medical scheme is older and generally sicker. And if you include that, the utilization, how people use their healthcare, whether they are going directly to a specialist and bypassing the general practitioner, or that care is mainly now delivered in hospital as opposed to out of hospital, those kinds of things are driving the cost of care. Right. And so a lot of the work that we're doing now is to see how we can change the way we deliver healthcare, how we pay for healthcare, to make sure that there's ability to reduce the contributions for the consumer.
So talking about paying for healthcare, I mean, you mentioned earlier that, you know, in the public sector, it's free at the point of service. And it's not entirely free because somebody pays for it. You and I pay for that.
That is true.
So?
That is true.
So if you look at expenditure generally, then, you know, in the private versus the public, how does that compare?
In terms of how much per life per month we spend.
Yep.
So generally speaking, the cost per life per month that's spent in the public sector is just over 2,000, whereas the cost per life per month in the private sector is just over 10,000.
It's a huge difference.
Yeah, it is a big difference, and I mean, it's driven by many different things, which we can discuss, I suppose, as we go. Right.
Talk about then, you know, taking this cost element, you know, a little further. You were a health market inquiry panelist, and looking at, you know, the timetable that was announced, you know, this goes back quite a few years. Just tell us a little bit about what the health market inquiry was established for, and yeah, what does it seek to achieve?
Okay. Yeah, thank you. The health market inquiry was established by the Competition Commission way back in 2014. After observing trends in the health sector for, I think about the previous 10 years, from 2003 to 2012. And some of the main drivers that resulted in this were basically the structural issues, expenditure trends, and regulatory what can I say, regulatory imperatives that were not being followed upon. And that led the Competition Commission to suspect that there were features of the sector that either prevented, distorted, or restricted competition. Now, this is important because if you do not have competition, it has been shown that either the price of care is higher than it should be, or the quality of service is lower than it should be. Now, what they basically suspected structurally was that you had 3 hospital groups that controlled more than 80% of the market. You had 3 medical scheme administrators that also controlled about 80% of lives under management. And when they looked at expenditure trends, from 2003 to 2012, they could see that the per capita increases on hospital services was about 40%, and the equivalent number for specialists was about 55%. And on a day-to-day basis, just healthcare, household healthcare expenditure was also about 4 percentage points higher than general inflation for other goods. So those were reasons that were key for the Competition Commission to set up the inquiry, which then started in 2014.
So just take us through the process then that you followed up to a point where you released your final report.
Yeah. The chair was the former Chief Justice, so he very clearly was certain that we were not going to be found wanting on process. And this was an inquisitorial type of process where we received written submissions. We did our own research, but also had public hearings, which were hosted in Gauteng, in Durban, and Western Cape in particular. So,
by public, you meant everybody was welcome to come and,
anybody
you
was
didn't
welcome
pre-select the people that attended?
Not at all,
Right.
because we advertised that anyone who wanted to make submissions, they could. And obviously, what our team that we worked with, which was seconded from the Commission, along with panel members, would obviously just rationalize so that you don't get 7 people talking about the same point. But we did go to great lengths to make sure that the various points were represented, and a lot of that was dedicated to consumers, because ultimately the perspective is what is good for the consumer. That was the main thing.
Yeah. So before we come to the findings, just to, overall, where to from here? Is this the end of the road for the health market inquiry?
Yes, the health market inquiry has completed its work. We handed the report to the Competition Commission at the end of September. And it now is up to the Competition Commission. But as far as I understand, that as is required, it has been submitted to Parliament. It's a question of when then Parliament will engage with the report to start the process of responding, hopefully drafting the laws to address the issues that we identified as problematic.
Okay. So it took some years, to come up with the final report. So we're not going to be able to cover everything, but just give us a sense of the main findings that the public would like would have interest in.
Yeah, I will just break that down systemic and look at the 3 main stakeholders of interest, which would be the hospital groups, the practitioners, and as well the funders.
Right.
Systemically, what we certainly found was that there is little regulation on the supply side, meaning that mainly the practitioners in hospitals really don't get much regulated beyond being licensed to be able to work in the private sector. On the funding side, which is the medical scheme broker side, there is regulation, but it's not complete. We found that the purchasing in the entire system is really not value-based. And that's a huge driver of costs, and we pin it down mainly to the fee-for-service system. We also found that the regulators could have done better to prevent the problems. We say the Department of Health has not implemented some of the acts that are already in the act. We say something about even the Competition Commission in how it has missed the creeping measures that land us with such high concentration on the part of your hospitals.
Right.
And within the consumers themselves, we do find that they are not understandably as knowledgeable as they could be, but we also do say that as far as anti-selection is concerned, we do see that they sometimes selectively purchase care when they know that there's a major life event, health event about to happen, and actually pull out afterwards.
And in terms of the funders and administrators?
Funders, we say the health plans are pretty complicated. They should be simplified so that consumers are better able to choose what will work for them.
Right.
There's high concentration in the form that there are few administrators indeed that control more than 70% of the market.
Right.
Even the medical schemes, 2 medical schemes, Discovery and Bonitas on the open scheme side, they already have about 71% of the market. And on the restricted scheme, GEMS and Polmed have also more than 50% of the market.
Okay, we're going to go into greater detail on that.
Yes.
Dr. Nyathi, I was going to ask you whether or not this is a surprise or is it something that we've always known, but unfortunately, I'm going to invite you back to, get your comments on that. For now, time for a quick break. When we come back, we'll continue our discussion on the cost of healthcare. Please stay with us. Welcome back. We're talking the cost of healthcare in this country with our HMI panelist, Dr. Ntutuko Bengu, and we're now joined by the chairperson of the South African Medical Association, or better known as SAMA, Dr. Angelique Kutsia. Welcome to Health Talk, Dr. Kutsia.
Thank you. Thank
All right.
you, sir.
I'm going to come back to you, but I just want to ask Dr. Bengu to just take us through. Now, let's zone in on the practitioner side, your findings so that we can have a discussion around that.
Thank you. Yes, we did confirm that what industry calls the tariff vacuum indeed exists. This obviously dates back to 2004 when the Competition Commission stopped how industry set prices, and practitioners were most affected by it, meaning that there really isn't certainty on the pricing. And obviously, whenever there is uncertainty, we do see that to an extent that drove costs higher. We also found that the regulator in the form of the Health Professions Council has not kept up with developments that would help with innovation that needs to be introduced. And so we made very specific recommendations on some of the parts of the laws and bylaws that could be amended to help this. We also did find that there is what is referred to as supply-induced demand, meaning that where practitioners, especially specialists, because this tends to be around hospitals in this regard as a driver of cost, that where there is an opportunity to treat at a lower level of care or maybe at a much sort of reduced frequency, there is the tendency that maybe we over-service. And as I said, that tends to be linked to the model that we pay practitioners. You do more, we pay more.
Okay, so let's tackle it piecemeal, because I'm interested to get your comments on this, Dr. Kutsia. Firstly, on the regulatory side, and secondly, on the over-servicing side. Your comment?
On the regulatory side, we do have a problem. The current medical schemes options are mostly hospital-centric based, tertiary care based. There's not enough monies available at primary health care out of hospital. So that tends to lead to more admissions for patients into the hospital, especially by the specialists. A lot of hospital groups, the three big hospital groups, will not allow a GP to admit a patient and treat them in one of their hospitals, except if it is in a rural area or there's no specialist available. And that is also leads to unnecessary higher costs that we incur. From SAMA's side, we had made a submission to the Minister of Health. Between the South African Medical Association and the Dental Association, we would like to become independent from the HPCSA, because we also feel that they don't deal fairly enough with our problems that is unique to the medical fraternity.
By independent, you mean SAMA?
Yes, independent. Okay. The South African Medical Association and the Dental Association wants to become independent, like the Nursing Council and the Pharmacy Council, so that we have more control over our own matters, and make sure that the regulations are being fair and implemented as to assist the medical doctors.
That's quite an interesting one. You still need a regulator of some sort. Dr. Bengu, your comment on that?
Yeah, this is an interesting development, and I suspect Doc has broken the news in your program. Look, I don't think I'm qualified to comment on the administrative issues that they obviously see, because I'm not involved at that level. But certainly as a registered practitioner myself, clearly one wants to see what is best for ultimately the consumer and patient.
Yeah. Right. There's a notion, of course, we need to talk about over-servicing as well, but you made a split. I think one of us spoke about, practitioners based in hospitals, mainly specialists, versus those that are placed out of hospital. And if you look at expenditure generally, the ones that seem to be associated, let me put it that way, associated with higher costs are the ones that are placed in hospitals. Your comment on that?
Yeah, it's true. Again, the problem is lying in the fact, again, as I've said, in benefit design. Benefit allows you to be admitted in the hospitals. Unfortunately, the PMB conditions also leads to abuse in the tertiary setup. Remember, in the primary healthcare setup, your PMB is ring-fenced by being part of a network of doctors. So they ring-fence the GPs on that and to keep costs down. But it's not happening at the tertiary level. So it means that I cannot treat you, let's say you run out of funds for high blood pressure. Your blood pressure is uncontrolled. Instead of trying to fix it at a primary healthcare level, you will be admitted in the hospital. Again, GPs will not have access to admit you themselves and try to bring, to regulate costs there as well.
Yeah. You mentioned PMBs now. Sorry, I just want to take you back to that issue of, the practitioner's responsibility insofar as managing costs. You mentioned PMBs. There's a very strong notion that, in fact, some of the practitioners, if not most of them, take advantage of this PMBs and want to wring costs as high as they possibly can. Your comment?
Yeah. But again, if you're not part of a managed healthcare group that help manage those costs, then you can charge for a admitted patient for hypertension, whatever you want to charge, and the medical scheme needs to pay for that because it's a PMB, it's written in the law. So what we find is that although there's a lot of regulation or medical schemes try to regulate the family practitioners or the GPs as we are currently known, we don't see that happening that much in the space of the specialists. It feels as if they are a bit afraid to tackle the specialists. They're a smaller group and they can stand up and say, listen, if we don't want to take this price, then we're not going to give you the services, and that's a bit of a difficulty. Now,
they're a smaller group, but they're responsible for quite a huge chunk of the cost, isn't it?
Yes, that's true.
Yeah.
So we need also to get regulation that patients go through their GP, and then from there being referred to a specialist. You cannot just say to me, I feel I need a specialist because there's something wrong with my heart, and therefore, doctor, you have to refer me to a specialist. No, you cannot do that. I first need to, at the primary healthcare level, need to sort you out, make sure that there is indeed a cause.
Okay.
But
before I give
happening.
Dr. Bengo a chance again, so I just want to put this question to you. What can practitioners themselves do to try and manage this obviously unacceptable situation where the costs are just so high?
At primary healthcare level, from the GP side, you need to do preventative medicine. You need to be very strict on preventative medicine. You need to make sure that you get the outcomes that is desirable for that patient, to give the right, I always say you need to give the right service at the right time, at the right place, at the right cost for the right patient. You cannot run feet through your practice if you want to do preventative medicine and with outcomes based. That unfortunately takes time. And if the medical schemes can start to reimburse doctors for who is looking after the chronic ill patients at the primary care level, not in hospital, that will reduce costs. Then on the specialist level, I think there should be more peer review on the specialists themselves, and also there's not guidelines. There's guidelines, but if you go and look what is happening in an ICU setup, it is as if you know, every specialist will do what he thinks is right,
Yeah.
not following the same rules that he would have followed if it was in a public sector.
Yeah.
So there's different rules for public sector patient treatment and what you do in the private sector.
I think there's just so much to talk about on this matter that I feel that we will make some time next year, sometime, to just focus only on this matter.
Yes,
but
we
thank you
have
very
to.
much for your time.
Thank you.
Right, time
Thank
for
you.
another quick break. When we come back, we now focus on hospitals. Please stay with us.
Mediclinic Southern Africa, the largest of the 3 international platforms, is an established leader in the well-developed, mature South African private hospital industry. Mediclinic Southern Africa has a network of more than 50 hospitals in South Africa and Namibia, with around 15,500 employees and more than 7,000 licensed beds. Mediclinic Southern Africa enjoys a market share of around 25%. There are attractive growth opportunities in the subcontinent, and the group works hard to ensure that those opportunities are pursued with new hospital acquisitions and internal facility upgrades to maintain a culture of clinical excellence.
We do expect modest patient day growth. We expect a strong performance from our primary care division. We're adding on another 61 beds to the Akeso network, and there's some nice growth opportunities in the pipeline.
At Life Healthcare, improving the lives of others is in our genes. We believe in the balance of life, health, and care. Because life, health, and care embody our beliefs. It is enshrined in everything we do. It's about dedication to well-being and quality of life. Clinical excellence in world-class facilities, quality service, respect, and a spirit of giving to those entrusted in our care. As one of the top JSE-listed companies, Life Healthcare is leading the way forward, consistently delivering strong financial performance. With our crystal clear vision, we see beyond where we are now. Our vision is to be a market-leading, international, diversified healthcare provider.
All right, welcome back, and thank you so much for staying with us. We're discussing the cost of healthcare. We're still with Dr. Bengu, and we're now joined by 2 other special guests. First, the gentleman in the middle is Dr. Stan Molwabi, who's the Chief Operations Officer at GEMS, and is the Principal Officer in waiting to take over from February 2020. Welcome to Health Talk, Dr. Molwabi.
Good morning, Dr. Mutau, and good morning to the listeners.
All right, and then of course we have Dr. Ryan Nosh, who's the Chief Executive Officer of Discovery Health. He himself is he's a qualified medical doctor, and there's a lot more I can say about him, but I'm not going to do that today. Welcome to Health Talk, Dr. Nosh.
Thank you. Thanks for the invite, Dr. Mutau.
All right. So we're talking here about the hospitals, and let's come back to you again, Dr. Bengu. Just briefly, outline your findings insofar as hospitals are concerned. I know we touched on it a little bit, but just for the sake of this discussion.
Yes, the inquiry did verify that Life, Mediclinic and Netcare, the 3 hospital groups, certainly have market shares of more than 80% by beds and even higher by admission. We found that hospitals actually do not compete for consumers per se, but they compete to attract specialists. And a key method of doing this is to acquire most expensive bells and whistles, which obviously the concern is that a return on those investments must be made. And the question is, to what extent is that also a contributor to the increase in costs? We found that I have referred to the supply-induced demand from the practitioners. Certainly, hospitals do benefit from that. They are not decision makers. Doctors decide who gets admitted where. But beyond that, of course, they benefit. We stress that we are not saying that they are drivers of that level of care.
But they certainly do decide on how many extra beds they can have, how many extra facilities they can build.
Well, but then there is always a regulator that gives them the license. This is where we found a lot of the problems. There are lots of licenses. Some of them can never be operationalized. And even the issue of beds, someone gives the license for the beds. What we can say, though, is that they are in full control of which specialist to give rights to practice within their establishments. And Doc Kutsie may have touched on this. We could also even tell the trend of which practitioners, specialists have got practice rights. Of course, you can see that maybe dermatologists wouldn't be many of those, but the surgical disciplines are preferred.
Yeah. Let's get a perspective from the administrators and the schemes. Let's start with you, Dr. Nosh. I mean, you deal with hospital groups on a regular basis, and I'm sure you'll concur with some of the findings. Just give us your perspective.
At the starting point, we should just keep in mind the fact that as South Africans who have access to private healthcare, and admittedly that's only a small portion of South Africans, but for those that do, the hospitals provide an incredibly good quality healthcare service, some of the best in the world. And so while the subject of your talk today is cost, we should just start by saying that we mustn't underestimate the value and the quality of care that we get, as good as, if not better than, most countries in the world from our private hospitals.
Right. We can spend quite a bit of time just trying to define what quality is, what's acceptable,
we can,
and
absolutely.
so on. But that's for another day. Yeah?
But we largely agree with Dr. Bengu's summary of the HMI findings. We think the HMI did a highly astute job in understanding the facility sector.
Right.
It is concentrated. I guess the one experience which would be useful for you to hear from our side is how tough the negotiations actually are between hospitals and us as administrators acting on behalf of schemes. These are extremely complicated, extremely onerous negotiations, and in our case, over years, have developed in quite sophisticated agreements wherein we try and share risk with the hospital groups. And 2 out of the big 3 groups that Dr. Bengu mentioned, we're in contracts where we actually share risk around the ultimate cost and outcome of the care that's delivered.
Right.
And we do that so that the hospitals are invested in some value. These are called value-based care arrangements, and we believe that aligning around value with the hospitals is actually what our members, what members of the medical schemes we look after require.
Yeah.
They want to get a high-quality service at the lowest possible cost.
Yeah.
And as Dr. Bengu correctly said earlier in your show, a big driver of cost is the fee-for-service system.
Right.
And these value-based contracts manage to mitigate that to some extent.
But are you seeing results from these value-based contracts yet, in terms of cost effectiveness?
We believe we are, and in fact the HMI recorded in their report that they saw evidence of what they called countervailing force, or ability to negotiate quite strongly with the hospitals from only 2 areas in the healthcare industry, and they listed those 2 as Dr. Molabi's GEMS and Discovery Health. And in those 2 areas, they did see that countervailing power.
Yeah.
So I think even the HMI documented benefit from these negotiations and benefit from the activities in GEMS and Discovery Health, which results in value.
All right, let's get a perspective from the medical scheme, GEMS. There was reference to negotiations and, tough, How transparent are they, by the way?
Well, I think between the 2 parties, there is an element, and underline an element of transparency, because these negotiations are based on a tariff that is already set. So, where our year-on-year negotiations tend to concentrate on what are the adjustments for the coming year, taking inflationary issues into considerations. So to answer you, to the extent that we negotiate on the things that are put on the table in terms of, from the side of the hospitals, whether in the input costs, there is an element of transparency. I think the problem in terms of what we are talking about is that was that base set at the right place in terms. So we all agree that the costs are generally high, and I think Ryan has basically mentioned value-based reimbursement, and I think that is really where we are going, because it shouldn't only be about access to these facilities. It should also be about the outcomes, and are we paying fair value for the services that are being rendered? We all agree that the hospitals are rendering an important service, and the quality of care, basically, South Africa is known to be having among the best quality in terms of health. But the main thing here is that, is it fair value for the services that are being rendered to the patients who use these services?
Okay. So whilst these negotiations are between the schemes administrators and the hospital groups, but the one important element within the hospital in terms of cost driving is the specialists or the providers that are based in the hospitals. How are these sucked into or at least incorporated into these agreements?
Yeah. So one of the things that comes out of the health market inquiry is supply-induced demand. And I think Dr. Tutuko has already mentioned the fact that specialists tend to drive the costs, and possibly because of the arrangements they have with the hospitals. So I'd love to share with you the fact that if we're talking about supply-induced demand, one of the interventions that we have come up with at GEMS is the care coordination. So where there's care coordination, and we have a specific option in our environment where we enforced care coordinations, and the result was that the hospital costs were down by about 12% as a result of the admissions going down into this hospital when compared to the options where we don't have care coordination. So those elements that are known to have been identified to cause an increase in costs, we are addressing them in this manner. And I think there is an opportunity for us to look at addressing those drivers that have been identified in the HMI. But we have to be innovative. It involves a lot of changes in behavior, both from the provider and both from the users of the services point of view.
All right. Dr. Benglu, I literally have about 30 seconds for you, just for your last words.
Yeah, no, I mean, Dr. Noach made the point about countervailing power. I do think that the issue that will be debated going forward is to what extent are we finding the right balance. We heard as well during the inquiry that Netcare said they had to stop construction of a hospital group because Discovery said they are not going to cover it. That suggests influence as well. The question is, where is the right balance? Because the countervailing power certainly is an important consideration to be made.
Right. Well, Dr. Bengu, thank you so much for your time and contribution. You can stay seated. Okay, now, quick break. When we come back, we'll wrap up our discussion on the cost of care. Please stay with us. Welcome back. We're talking the cost of healthcare still with our guests, Dr. Nyati, Dr. Malabi, and Dr. Noach. And let me put it out to you, guys, because here we're focusing on the role of administrators and the role of the funders in trying to manage costs. All right? The first thing is the whole hospice-centric, way that medical options are structured, or some options, in fact, you get hospital-only kind of options, which in fact drive services into hospital. I'd like your comment on let's start with you, Dr. Noach.
Thank you. That question is really driven by two structural phenomena.
Yeah.
The one is the regulations, which have a set of prescribed minimum benefits, commonly referred to as PMBs. And those PMBs mandate that medical schemes in South Africa, according to the Medical Schemes Act, have to, by law, cover a certain prescribed set of conditions.
Yeah.
And guess what? Many of those conditions are covered in hospital. And so medical scheme funding and the entry cost of a medical scheme product in this country is really largely determined by that package of care, that package of benefits called PMBs that needs to be covered largely in hospital.
Yeah.
And by the way, it may be interesting to you to know that the cost of that product, just the prescribed minimum benefit cover, nothing more than what the law requires, is about 900 Rand a month now in South Africa. And that therefore creates a basement price in the medical schemes industry.
Yeah.
The second issue is that structurally the way our healthcare system has evolved in the past is that it's been built around big hospitals, acute tertiary care hospitals, where the specialists tend to be resident and where most of the tertiary and secondary care is delivered.
Right.
And we would love to see a market where there are much more day surgery networks, where there's much more out-of-hospital cover. If you compare our proportion of in-hospital care to out-of-hospital care in South Africa, relative to many developed healthcare markets around the world, it's completely skewed to in-hospital.
Right.
So much of the work we've been doing in Discovery has been to try and drive members to the appropriate site of care, which may not be in a hospital.
Right. Let's get a schemes perspective.
Well, in addition to what Dr. Nocha said, the regulatory environment has been such that it has favored hospital-centric type of care. I think one thing that has evolved over the past 2 decades or so, maybe even more, it's a move away from primary health care, where you find that if you look in the insurance industry, because members would know that their day-to-day benefits are now limited.
Yeah.
So the tendency would be to only seek help for curative basis. You wouldn't go to the doctor just to go and do preventative type of care. And as a result, what basically happens is that we have lost the war on preventative health as such. And people tend to, the patients tend to only seek help when, you know, disease is advanced. And this also supports the hospital-centric type of our health care. And at that level, already the costs are much higher, whereas the focus should have been on preventing, such that utilization of hospitals is reduced because we have healthier regions. I mean, that's idealistic, but when you think about even the inputs into how national health insurance should come about, I think primary health care is being purported to be the focus of how healthcare should be done. And I think that the country would be going in the right direction when we look at primary healthcare, and then it is supported by you know, the tertiary healthcare.
Okay. Dr. Nita, I'm sure you'll have some comments to make, and especially I'd like you to also touch on the issue of, you know, supply and just demand, to say what exactly can we do or are we doing to try and manage the situation?
All right. First, let me touch on something that consumers can take responsibility for to a certain degree. In the previous segment, Dr. Mulabi spoke about care coordination, and what that means is it is better to have care that starts in a preventative space. So people who don't have disease first must prevent as best as possible, because if you can prevent, then you reduce the cost down the line. Then it's equally important that when you do require care, you start with your general practitioner and then let the general practitioner refer you to a specialist, and if hospital is required, into hospital. But we're finding that consumers in South Africa prefer to go directly to a specialist and bypass the general practitioner and even go to the hospital directly by themselves and seek care. And we've found that where there's poor care coordination, you can increase the costs by up to 3 times. And so we spend a lot of our time as funders assisting both the providers as well as the consumers to follow paths of care that will lead to reduced care. So we've put up networks, for example, and we even try to help consumers that when they go to a GP, we make it easy for the GP to refer to a specialist, to refer to the right specialist, good outcomes, and then to also refer to a network hospital where we've put in place mechanisms to ensure that the costs are low and the quality outcomes are there. So those are some of the things that I think consumers can start thinking about actively is, one, am I doing all the things that I need to do to make sure that I stay healthy?
Yeah.
If I'm already got a chronic condition, am I looking after it well? And then when I need care, how do I start with my GP? How do I choose a GP, stay with the GP and let the GP then manage the care? That will really help in reducing our costs.
Yeah.
A lot of the health records that we've come up with are there to assist a consumer understand their healthcare better and then make sure that they go according to care. To your topic about supply-induced demand, Stan spoke about it a little earlier in the sense that we've found that where we've got an oversupply in our language of beds, then those beds will be filled. There's a law called Rumour's Law. If it's there, it will be filled. And so part of what we've been doing a lot at MedScheme is scanning the market and the beds really well according to the 3.7 million lives that we look after to see whether or not when a new hospital needs to come up, is it coming up in an area where there are already so many hospitals within a certain vicinity. Because the more we can make sure that care is at the places that are required, the better it will be, one, to reduce the cost, but also to make sure that access is good. And that's one of the ways that we manage supply-induced demand. And then there are obviously things like the PMBs that Dr. Noach spoke about, that in itself creates supply-induced demand.
All right. Just in wrapping up, I'm going to give each of you 30 seconds or so just to wrap up your final thoughts on how we can manage this problem. I mean, the one criticism was around, the fee-for-service model that we have. Yeah.
We need to work together as currently fragmented stakeholders in the healthcare industry. We need to form teams of care. We need primary care doctors and specialists and hospitals working in multidisciplinary teams, providing the most appropriate care at the most appropriate time to the patient. We're happy to invest in quality early because good quality up front leads to lower cost in the long term.
Right.
So multidisciplinary teams with good data working together is the answer.
Dr. Brady?
I absolutely agree with that we really need collaboration is the way forward. But I think an important thing that has been mentioned earlier is care coordination, because in an environment where referral system is not appropriate, supply-induced demand drives the cost and utilization goes high. And of course, I think it is important that we engage with the suppliers of the healthcare services on the issue of setting the tariffs at the right level where there is a benefit from a value-based reimbursement point of view.
Dr. Nyati, last 30 seconds.
My last 30 seconds is that consumers need to understand more, and we are working a lot in our space to put in place mechanisms to assist consumers to understand better. The better we look after our health, and the better we, for those that have chronic conditions, look after their chronic conditions and use all the prompts we send. We send SMSs to remind, do the tests. And the better we do that, we'll also reduce some of our costs in the chronic space.
Okay. Well, gentlemen and lady, I'm sure this is not the last time we'll touch on this topic because it's quite an important one. And next time we'll have slightly more time than we do. But thank you so much for your contribution.
You're welcome.
And to you folk at home, thank you so much for being with us. We're back with you again in a week's time. And until then, please do take care.